Welcome, everyone. Welcome. Good evening to you all. We are spread throughout the East Coast of the United States at this point. Many of us in Florida, in Fort Lauderdale area, and we really welcome you to our wonderful symposium. The topic today is emerging trends in gastroenterology. We are going to have lectures from the team in Cleveland Clinic, Florida. And we have about 1,200 attendees from across the world registered for us from more than 90 countries, and we welcome you all. Want to give an acknowledgement for support of this activity by Cook Medical, Janssen Biotech, Medtronic, and the Olympus Corporation of the Americas, and we're grateful for your support that makes this activity possible. So again, myself and Dr. Kim will be hosting our stellar faculty from Cleveland Clinic, Florida, Dr. Adalberto Gonzalez, who's going to be talking about new medications for eosinophilic esophagitis. Dr. Gonzalez is the lead in Florida for eosinophilic esophagitis and eosinophilic disorders. Dr. Bayarma Manzieva is going to be reporting on when to hold GLP-1s for endoscopy. I know this is quite a hot topic, and some are estimating as many as 6% of our patients are using this medication, so it's very timely that we discuss this topic. Dr. Asad Rahman is going to be talking about his choice for IBD medications. Dr. Rahman is the director of our Inflammatory Bowel Disease Center in Cleveland Clinic, Florida. And we're going to have case presentations from two of our rising stars, Dr. Cristina Fernandez and Dr. Nina Petball. And hopefully we'll make this interactive. Also, please utilize your chat boxes and chime in whenever you'd like to have us answer these questions. Thank you, everyone. And let's get started with Dr. Gonzalez.
All right, thank you for having me. I'm Al Gonzalez, and today I'll be talking about new medications for eosinophilic esophagitis. So our objectives will be to go over goals of treatment, available medical therapies, my medication algorithm, and emerging new therapies. The goals of medical treatment are really to decrease esophageal inflammation, right, by decreasing eosinophil counts, preventing esophageal fibrosis and stricture formation, and thus the need for repeated dilations, and ultimately to improve symptoms and quality of life, really reducing food impactions and ED visits. It's difficult to talk about the treatment for EOE with at least acknowledging the pathophysiology and pathogenesis of EOE. But essentially, the most important things to know is which chemoattractants and chemokines they really target, such as TSLP, IL-33, IL-4, IL-13, IL-5, and eotaxin-3, among others. And there are some of the examples of which target which cytokines. What are available medical therapies? Well, PPIs are still considered first line due to their low cost, ease of use, and really wide availability. And it's not just about decreasing the gastric acid production, but also about blocking that Th2 eotaxin-3, which attracts all the eosinophils to the esophagus. And here you can see on the right a basic science study in which a patient's esophageal biopsy slide shows the effect before omeprazole and after omeprazole. And these are stained for eotaxin-3 and eosinophils, and you can see the wide difference. PPIs are about 40% effective at meeting histological endpoint of less than 15 eosinophils per high power field. But throughout studies, they've shown that there's probably more response in inflammatory subtype rather than stricturing subtype, and with an odds ratio of about 4. There's also higher rates of histologic remission if you use a BID rather than once daily dosing, as seen in this Red Journal study that came out this year. And it doesn't matter whether you use 20 BID or 40 BID, but it does matter, it seems, if you use BID rather than once daily dosing. Swallowed topical corticosteroids have also been around for a while, since about 1998 for EOE. And essentially it has several mechanisms for reducing esophageal inflammation, such as decreasing the type 2 inflammatory cells like eosinophils, mast cells, T cells, but also reduces tissue remodeling and restores barrier function. And there is also some inhibition of IL-13. This is a 2020 systematic review that looked at 8 randomized controlled trials, and it showed really that steroids are about 65% effective in achieving the histologic remission. But the problem with topical corticosteroids has always been, of course, the impedance of having really an easy way to obtain them. Usually you have to go through a compound pharmacy and mix it with sugar or, inhale it, very different things, which, really may alter compliance and availability. But luckily, earlier this year in February 2024, the FDA approved budesonide oral suspension, 2 milligrams twice daily for 12 weeks. And it makes things very simple. This already comes in a prepackaged thixotropic component. So essentially what that means is if you shake it, becomes liquid, becomes easy to swallow. And once it hits your esophagus, it becomes a little bit more slurry-like. So this really helps with the ease of use and transport, gives you a more reliable dose throughout the esophagus, and gives you a more reliable distribution, both proximally and distally, and really eliminates variability. This is the phase 3 trial in which got it approved by the FDA. And this essentially took about 300 patients aged 11 to 55 that had difficult to treat EOE. About 200 of them received budesonide oral suspension, 2 milligrams BID versus placebo. And you can see they use a stringent histologic response of 6 eosinophils or less. And you can see it blew placebo out of the water, 54% versus 1%. And not only that, you also want to see a dysphagia symptom response. And using the DSQ score, it also had significantly reduced dysphagia compared to placebo. And like I said, this was not an easy to treat group. All patients had already failed PPI, and about 40% had previous dilation for esophageal strictures. Of course, with any medication, there may be adverse effects. And with the budesonide oral suspension, we kind of knew what to expect, right? The main thing that you'll see is esophageal candidiasis. This was a little lower than has been previously reported, but was about 4% for oral candidiasis and 4% for esophageal candidiasis. But it's important to note that most of these are asymptomatic. Most of these you will catch when you're doing your surveillance endoscopy. So most of the time you will not have to stop treatment. You can continue treatment and treat with oral fluconazole. What about biologic therapy? That's the new kid on the block. Dupilumab is currently the only approved biologic therapy for EOE, and really what it does is it inhibits IL-4 and IL-13, key drivers of type 2 inflammation. It's been approved since 2022 for ages 12 and above at a dose of 300 milligrams sub-Q every week, as long as they're 40 kilograms or more. And it's also been approved as of this year for ages 1 and above. And here you can see a little bit of the downstream effects of this IL-4 and IL-13 inhibition. This is a phase 3 trial from the New England Journal of Medicine. Again, that got it approved for the FDA. Again, there were about 300 patients, difficult to treat. 200 received dupilumab. The rest received placebo throughout the study. And here you can see once again that there was a robust histologic response when you compared it to placebo, 60 versus 5%, not only for weekly dosing, but for every 2-week dosing. And again, this was a difficult to treat group, as all patients had failed at least 8 weeks of PPIs, and about 40% had dilations that needed strictures that needed dilation. So we spoke about both every other week dosing and every week dosing having histologic response. But the reason that we use every week dosing is because there was a clear difference in the dysphagia response when you compared weekly dosing to every 2-week dosing, especially here starting around week 9 to 10. So that's why we use once-a-week dosing. Adverse effects of dupilumab, well, they were quite common in both groups, including placebo. The most common thing you'll definitely see is injection site conditions. But again, all of these are mild to moderate and resolved. And there's ways to get around it, and none led to discontinuation in the study. There are other things that you may see that you'll pick up in clinical practice. Some additional considerations for dupilumab. Again, it was studied and approved for 52 weeks. And I like to tell my patients that it's been approved for even longer for other atopic diseases, such as atopic dermatitis since 2017. It's also important to know that dupilumab seems to be pretty good for even severe treatment refractory and fibrostenotic disease, even though the original trial excluded patients in which the scope could not be passed into the stomach. This study looked at a retrospective cohort of 46 patients with fibrostenotic EoE, and they also showed that dupilumab had very good response. And not only that, they showed that without dilation, there was an increase in diameter from 14 to 16 millimeters just from using the dupilumab without dilation. So when I think about my medications, I do think that dupilumab seems to be the most effective. Here we're looking at less than 15 eosinophils per high power field. And budesonide is also quite effective. Effective in fibrostenotic disease, I think dupilumab has shown pretty good evidence for that, but probably budesonide, you can extrapolate that it does have effect in fibrostenotic disease, as the trial did show that. The only thing with dupilumab is it is injectable, so it may be off-putting to some patients. When we think about safety, probably PPIs tend to be the safest, but definitely budesonide and dupilumab seem to have short and long-term safety. When we talk about cost, really budesonide and dupilumab will be somewhat insurance dependent. Otherwise, costs may be prohibitive. But PPI seem to be, of course, very widespread, available, and cheap. So when I think about my medication landscape and where I place medications, once I make the diagnosis of EoE, I ask the patients, do you want treatment or do you want dietary therapy? Some do prefer dietary therapy, but I think the majority like medications. So if we're going to start with medications, usually, like I said, first-line medication, PPI, BID. If the patient has fibrostenotic disease, then we may consider earlier budesonide or dupilumab because, like I said, PPIs tend not to work as much for fibrostenotic disease, while budesonide or dupilumab, and you should already be considering esophageal dilation. However, if you go down the PPI route and you see non-response, then consider the suspension. And if you see non-response from that, consider dupilumab. I may have already considered dupilumab if the patient has severe atopic diseases otherwise. But if I went down this route and they show non-response, you may consider combination therapy or even a clinical trial. Something you may run into your clinical practice are patients that have normal eosinophils once you place them on treatment, but they have persistent symptoms. And the next thing that you should really consider is esophageal dilation. Even if the esophagus looks normal to you, you may want to empirically dilate them to see if it improves their symptoms. And usually want to reach about 16 to 18 millimeters. Response, once you have response, make sure you put them on maintenance therapy and do monitoring. What's on the horizon? Well, there have been many, many studies, some that we don't use and some that we do use. When we talk about no improvement, that'll be things like anti-TNFs, immunomodulators, montelukast, cromolyn, and opolizumab, which is anti-IgE therapy. Systemic steroids do work, but they don't work significantly better than topical steroids, and the side effects just aren't worth it. There are several medications that actually improve histology but not symptoms. One of those is larentelimab, which is a cyclic 8 inhibitor, which showed good histologic response but not improvement in symptoms. And it seems to be also a class effect of the IL-5 inhibitors, including a recent trial that was published a couple months ago, benralizumab, which is an IL-5 inhibitor, which had a very robust improvement in histology, 87%, and that's the 6 eosinophils or less per high power field, but no improvement in dysphagia. Promising medications coming up soon would be cendakimab, which is an IL-13 inhibitor. This recently completed a phase 3 trial, and this is data from ACG this year. And again, difficult to treat population, histologic improvement in 20 versus 2%, and also improvement in DSQ dysphagia score. So once you have those two improvements in a phase 3 trial, I think we're getting closer to approval. Another promising medication would be etrasimod, which, as you know, is used also in ulcerative colitis. And this last year completed a phase 2 trial with about 100 patients and showed histologic improvement in 24 versus 0%, and also improvement in DSQ dysphagia score. So something probably that will go to a phase 3 trial. And then more emerging therapies would be things like other formulation of steroids and other mechanisms of action, but not much is known about them just yet. So my take-home points, PPIs are still a solid first-line medication. But if you have fibrostenotic disease, consider quickly stepping up to topical steroids or dupilumab, or in the future, another biologic. But new medications are on the way, so make sure to stay up to date. those are my references. And thanks for having me.
Thank you, Al. That's fantastic. Just one quick question that came up by Dr. Desopoulos was whether or not JAK inhibitors have been tried.
Yes.
like UPA. And, yeah.
Yes, there's been JAK inhibitors, but again, they did show some histologic improvement. But again, when you look at the side effect profiles of possible using JAK inhibitors, when it comes to all those things with that class, whether it's clots, immunosuppression, herpes reactivation, those things, ulcer reactivation, it just hasn't been approved for that reason, just because it's just not worth it. And ultimately, the dysphagia doesn't improve a whole lot. So the histology does improve. There is a decrease in eosinophilia, and the symptoms improve a little bit, but it's just not worth the side effect profile, adverse effects.
Excellent. And I really appreciate what you said about the dilation if the patient's histologically responded, but they're still having issues, because even though the lumen may look like it's about maybe 15 millimeters, where most patients that have a single stricture tend to feel a lot better once you get there, it's different with the EOE patients. It's longer area of this motility. And so they tend to have a much harder time, even at like a 15 millimeters. So sometimes getting them up to 18 or even higher may really help them.
Yeah, what I tell my patients usually is, it's not just about the diameter. It's also about, some degree of dysmotility. If you've had all this chronic inflammation that has gone unchecked for years, and you have this fibrostenosis and this remodeling, even if we bring you to a bigger size, it may not work right away. So, getting to a goal of 16 to 18 definitely, or even larger, definitely helps. And to your point, definitely, us as gastroenterologists, we're not good at perceiving if people have esophageal strictures. There's actually been multiple studies, including one from Mayo Clinic, in which they had gastroenterologists look at the same endoscopic images or during the same endoscopy. And, even 13 millimeters or less, we were only able to pick up that these are strictures in about a quarter of the time, 25% of the time. So that's interesting as well.
Yep. Thank you. Excellent lecture. Thanks so much. We're actually exactly on time. Let's move on to GLP-1s. This is becoming a bit of a bane of existence for those of us that do endoscopy when patients show up and we need to now figure out on the spot, are we going to go ahead and do this, or are we going to hold off on doing the endoscopy? So, Dr. Manziva, take it away. The floor is yours.
All right. Can you see my slides?
Not yet.
You will want to go ahead and share your screen. Click the share button.
What about now?
There you go. We can see it. Excellent.
All right. So I will talk about when to hold GLP-1s for endoscopy. So currently policies across Cleveland Clinic hospitals is to hold these medications such as semaglutide, dulaglutide, liraglutide. You can see here, like, you probably know them by names of Ozempic, Mounjaro. If it's injectable and it's for 1 week dosing, so it's to hold it 1 week prior to the procedure. So what are the evidence behind it? And there is an article that I want to discuss. It was published by AGA in April of 2024, and it's pretty much clinical practice update on the management of patients taking GLP-1 receptor agonists prior to endoscopy. So here's the clinical dilemma. So American Society of Anesthesiologists recently released the following consensus-based perioperative guidance. They recommend for patients on the daily dosing, consider holding GLP-1 agonists on the day of the procedure. For patients on a weekly dosing, consider holding GLP-1 agonist a week prior to the procedure or surgery. This suggestion is irrespective of the indication. It could be either type 2 diabetes or weight loss. It's irrespective of the dose or the type of the procedure or surgery. If the patient has no GI symptoms, but the GLP-1 agonists were not held as advised, they recommend proceed with the full stomach precautions. As a result, anesthesia providers have begun canceling or postponing endoscopic procedures in the patients taking this class of medication who require sedation or proceeding to general endotracheal intubation in some situations, which may lead to added time, cost, and clinical risks to many patients. Many facilities and medical centers are now struggling to revise pre-procedural protocols for patients taking this class of medications, despite the lack of high-level evidence regarding how to proceed. So what is the background? We all know that GLP-1 receptor agonists, they mimic incretins, which are hormones released after eating that prompt glucose-dependent insulin release from the pancreatic islets. They stimulate satiety centers, they inhibit glucagon release, and result in diminished gastric emptying. So patients receiving GLP-1 receptor agonists may have gastrointestinal symptoms, such as nausea, vomiting, diarrhea, or constipation. And it's been known that GLP-1 agonists, they increase gastric residue in patients with diabetes undergoing upper endoscopy. They has been shown to inhibit gastropancreatic function by interfering with the central parasympathetic outflow. On top of the nausea, vomiting, diarrhea, and constipation, there is increased risk of gastroparesis, pancreatitis, and bowel obstruction. So what are the clinical strategies? So it's appropriate that the ASA perioperative suggestions, they labeled as a consensus-based guidance. So they use words such as suggest, consider, and advised. And we need to understand that those suggestions are expert opinions, which may inform but should not replace a clinical judgment. These were among the reasons why there was multi-society statement published by American Gastroenterology Association, American Association for the Study of Liver Disease, American College of the Gastroenterology, and American Society for Gastrointestinal Endoscopy, and also North American Society for Pediatric Gastroenterology, Hepatology, and Nutrition. So they said that given the conflicted results from clinical studies regarding the risk of aspiration and gastroparesis due to GLP-1 receptor agonists, along with the possibility of such effects being dose or indication dependent, the societies concluded that there is insufficient data to support stopping GLP-1 receptor agonists before elective endoscopy. So authors suggest that individualized approach be taken to managing patients on GLP-1 receptor agonists in the pre-endoscopy settings. The clinical team should be cognizant of the indication for GLP-1 receptor agonists because cessation in patients relying on these medications for diabetes might actually provide more risk than benefit. Additionally, the dose and frequency, other comorbidities and medications, and most importantly, gastrointestinal symptoms, side effects should be noted. If the patient taking GLP-1 receptor agonists solely for the weight loss purposes, if that's identified beforehand, a dose of medication could be withheld before endoscopy with likely little harm, although this should not be considered mandatory or evidence-based. Nevertheless, it's unclear if withholding the medication for only one dose would be reliably adequate for individuals' gastric motility to return to normal. Similarly, there is insufficient evidence to suggest that this practice to be performed for patients taking these medications to treat diabetes, particularly because good glycemic control is very important before sedation and anesthesia. Consequences of the ASA preoperative suggestions are that by adding more complexity to peri-procedural medication management, this may necessitate enhanced nursing resources, which are already scarce, and exacerbate barriers and care delays for patients requiring endoscopic procedures. So generally, in patients on GLP-1 receptor agonists who have followed standard perioperative procedures, typically 8-hour solid fast and 2-hour liquid fast, and who do not have symptoms of nausea, vomiting, dyspepsia, or abdominal distensions, we advise proceed with the upper or lower endoscopy. In symptomatic patients for whom delaying endoscopy may have negative clinical consequences, rapid sequence intubation is consideration. However, this may not be possible in ambulatory or office-based endoscopy settings. Lastly, when possible, placing patients on a liquid diet the day before sedated procedures may be a more acceptable strategy than stopping GLP-1 receptor agonist and more consistent with the holistic pre-procedural management. So the home message here is that GLP-1 receptor agonists can cause delay in gastric emptying, and while the American Society of Anesthesiologists recommend holding these medications prior to all procedures, The American Gastroenterology Association, along with other organizations, they recommend individualized approach prior to endoscopy due to inconclusive clinical data. Of course, this may change with time as newer and larger studies become available in the future, assessing the direct impact of perioperative use of GLP-1 receptor agonists on patient outcomes. So I think we also have a study here that's ongoing for GLP-1 receptor agonists.
That's right. We're doing a randomized study right now, prospective randomized study. We're taking patients who are coming in already on one of the GLP-1s and without telling the endoscopist. These patients are randomized prior to arrival on either holding it or not holding it, holding it a week, 2 weeks, or not. And we're very curious to see what this is going to show. What do you think about that, Baya? Do you think that in your experience so far, do you feel like this is something that we should be doing? I know that our own policy right now is pretty restrictive. Do you feel like we've kind of gone a little overboard with it? What do you think?
I think we need to do more studies, and I'm glad that this study is ongoing right now. I actually did a procedure on one of my patients who did not stop GLP-1, and he had absolutely great empty stomach and absolutely perfect bowel prep. So, and he was taking his medications on the day of procedure. So, and of course, it's also difficult to say because a lot of patients who are on GLP-1 for the diabetes, they may have underlying gastroparesis already, so it may not be due to medication itself. So I think more studies needed, and I think asking patients before the procedure if they have any symptoms is also very important.
Interestingly, our own group actually published a study. I think, Al, were you a part of that study on the colon preps for diabetics on GLP-1s?
No, that was before my time.
That was referred.
Yeah. But you know, interestingly, yeah, I mean, I was actually going to bring up that point. I think our anesthesiologists have been a little bit more liberal. So I have seen quite a few patients, not in this study, but that have been getting endoscopy and colonoscopy. And honestly, I think the endoscopies have gone fine. I haven't really had to cancel. I think more of an issue has been the bowel prep. I get these, adequate bowel preps, fair bowel preps, so, I think that may be an issue more.
Yep. So we're getting some consensus. It looks like everybody, so far the respondents from chat, there's one dose prior to holding one dose prior to procedure, which essentially is if it's a once a day oral medication, you hold it the day before, and if it's a once a week medication, you hold that last dose. So it ends up being a week, which is Dr. Bott also reports that offer 1 week per anesthesia since they control it, right? And Dr. Sutton is asking whether or not they cause ulcers at all in patients. I'm not aware of this really. What do you think, Dr. Manziva? Is this something that...
I haven't seen that in the studies that they were direct.
I haven't seen that in practice. I'm not sure if anyone else has. And here's from Iffy. If a patient with Ozempic presented with constipation, colonoscopy was actually negative. Patient says she's drinking a lot of water, taking Colace. It is not working. What is the next step? Stop Ozempic. Well, good question.
They usually start with a dose reduction.
Yeah. Well, that's great. It's a bit off topic, but that's good advice. Excellent. All right. If we're don't have any other input, I guess we could move on. Any final words, Dr. Manziva, about GLP-1s?
No, I think just the main point here is to use clinical judgment when we do it. If it's for the weight loss, I would say holding it doesn't hurt the patient, but if it's for diabetes, I think clinical judgment is important here. For now, we're following the policies published by ASA, and we'll see what the future will show.
Excellent. Thank you very much. That was really well done. And moving on to Dr. Asar Rahman, our Director of Inflammatory Bowel Disease, the person who is constantly bothered by for every single second opinion that comes to us for inflammatory bowel disease. It feels like he's going to give us. This is exactly why we picked this topic for him to get his sage advice on his choice of IBD medications.
Hi, can you hear me? Okay.
Yeah, I can hear you. I can't see you, but I can hear you.
Okay. I think
There you go.
my camera is on and I think everybody can see my slides. Good evening, everyone. My name is Asadur Rahman. I'm part of the gastroenterology group here at the Cleveland Clinic in Weston. Before I begin this topic, I also recently attended the Advances in IBD meeting and talking about GLP-1 analogs. What I also learned was there was some data shared about GLP-1 analogs and the relationship with IBD activity, and there was no signal that mentioned any exacerbation in IBD activity and GLP-1 analogs. In patients who have IBD, it is okay to use a GLP-1 analog if that's what their metabolic profile needs. So moving on to my own topic, which is the choice of IBD medicine. And it's a very loaded topic. And I think this is something that's very, very important and pertinent to the majority of us who take care of patients with inflammatory bowel disease. Instead of approaching it in a very, individual scenario-based, approach, I try to take a 30,000-foot view and really go over the thought process that comes when we are, approaching this with every patient, because, no two patients with IBD are the same. So I'm going to go over, certain broad areas which actually influence clinical decision-making in IBD. This is my disclosure. So in terms of therapy options for IBD, although today's topic of mine talks about medical therapy, I also wanted to emphasize that patients with inflammatory bowel disease, they require a multidisciplinary approach. And I cannot, emphasize the importance of other specialties that we also involve in the care of patients with inflammatory bowel disease, be it Crohn's disease, ulcerative colitis, and rarely, even microscopic colitis as well. So although I'm going to focus on medical therapies, we do include our colorectal surgeons in our clinical decision-making. I emphasize that to our trainees as well as to the patients that surgery is not the last option. Sometimes it is the best option, and it is always one of the options for therapy for IBD. We are blessed to have a good dietitian and nutritional support in our department, and it's very important to address that when we are taking care of patients with IBD. And on rare occasions, complementary and alternative medical therapies may need to be considered on a case-to-case basis, but won't be the topic of discussion today. So one of the key takeaways of the AIBD meeting in the last 3 days, which actually perfectly, blends in with today's topic about the choice of therapy, is probably the most important thing when we decide therapy is the timing of therapy. Remember that inflammatory bowel disease is a chronic inflammatory condition, and over time, when this inflammation is uncontrolled, there are chronic changes that happen in the bowel architecture, and this can be, especially in Crohn's disease, lead to strictures, fistulas, abscesses. So instead of focusing a lot on types of therapy, I think the most important thing is to identify this early on, which was actually emphasized in the recently published randomized study that was called Profile, published out of Oxford, that looked at patients who were initiated on medical therapy within 2 weeks of diagnosis, and the ceiling of therapy, as we call it, inflammatory bowel disease, for the majority of the medicines, we haven't been able to break beyond 40 to 50%. In that study alone, the response rates approach 70%. So the difference between that study and what has previously been published before has been the window of opportunity that wasn't missed in that study. So I think that's what I want you to know, is instead of, having a prolonged discussion that can span over a couple of office visits, it's important to identify that the window of opportunity can be very small for some patients with inflammatory bowel disease, and be it ulcerative colitis or Crohn's disease, but discuss that with your patients early on, because if we control disease early on, we actually lead to avoidance of prolonged, architectural distortions, need for surgery, hospitalizations, prolonged steroid courses, and etc. So timing is very important. And before I go over the clinical decision-making, we also spend a lot of time in the clinic discussing what the goals of therapy are. Sometimes the goals of therapy are different between the providers and the patients. For us as healthcare providers, physicians, our goal is to help get patients, when we ask them questions, how many times are you going to the bathroom? Are you having an improvement in urgency and bleeding? We want to have a response. We want to see a clinical remission. We want to see their biomarkers, the CRP and CalPro, go down, and have their endoscopy start to look from here, which is severe Mayo 3 ulcerative pancreatitis, to what almost normal looking colon. However, the goals for patients may sometimes be very different, and that's steps when we approach that in the endoscopy recovery area for somebody with a newly diagnosed inflammatory bowel disease or in clinic, their answers may be very different to what we think they may require. I mean, they probably will be looking to get back to enjoying life, having a normal dinner with their family, to be able to take medicines at their own convenience. So I think those are sometimes the most important factors when patients are looking at therapeutic options. So again, it's important to address those early on. I mean, initiate, conversations about what short-term therapy may look like, what medium-term goals are, and what long-term goals are. And it's important to have that aligned between ourselves and the patients. So looking at the therapeutic landscape, I mean, over the last 70 years, we've had a significant explosion in terms of the number of therapies that we've had at our disposal for IBD, especially so in the last 25 years. In 1955, we realized that, steroids are helpful for acute severe ulcerative colitis. The study was done in the UK where, cortisone works save patients' lives. I mean, it's something that we consider as mainstream therapy for patients with IBD currently. But at that time, we didn't know that. So in 1955, I mean, that led to a significant breakthrough. And over the course of the next 30 to 40 years, we came to realize that 5-ASA medicines are helpful. Immunomodulators like azathioprine and mercaptopurine and methotrexate became more and more available and were approved for therapy for inflammatory bowel disease. But then in the late 1990s and early 2000s, we got enough research to identify molecules that are actually driving the inflammatory markers or inflammatory cascade in IBD, and got to subsequently get infliximab, followed by several other anti-TNF agents, followed by anti-integrin therapy, anti-interleukin therapy, S1 receptor modulators. And in this current year alone, we've had several other agents that have been approved for IBD. So our menu of therapy, or the options we have for therapy, has significantly expanded. So again, it helps improve care for our patients, but it's important to realize that these options haven't really broken the therapeutic ceiling. And I believe that's why timing and initiation of appropriate therapy is everything. So these are the factors that I take into consideration when I'm choosing therapy for IBD for patients. We look at the location of disease, the assessment of disease severity, not just by clinical symptoms, but also with some kind of cross-sectional imaging, endoscopy. We look at the efficacy of approved therapies, their safety, their routes of administration, any extraintestinal manifestations or comorbid conditions, and ultimately, last but not the least, insurance, which plays a very significant role in which we actually choose therapy for our patients. So location, current, the landscape in terms of the property, and it's all about location. So patients with ulcerative colitis, the majority of the patients begin with having ulcerative proctitis, which in a significant proportion of patients over the first 6 to 24 months may extend towards left-sided colitis or pancolitis. So in patients, the location of disease is important, because if it's mild to moderate disease, you may consider topical 5-ASA therapies, topical steroids, and as the disease extends into the left side, you may consider enemas with concomitant oral 5-ASAs from mild to moderate disease. However, if there is severe disease, it doesn't matter where the location is. If it's moderate to severe ulcerative proctitis, many times the 5-ASA won't work. And in that situation, you may start, and you should start, with an advanced biological therapy, whatever is approved by the insurance and acceptable for the patient. And again, as the disease extends, it may lead to more and more symptoms. And so again, the most important thing is also not just the location, but also the severity of disease condition. What about Crohn's disease? Crohn's disease, the most common area of involvement of Crohn's is the terminal ileum. Now, Crohn's can be very, very different for different people. It can have an inflammatory phenotype, it can have a penetrating phenotype, it can have a stricturing phenotype. So in patients who have a predominant inflammatory phenotype, this is your window of opportunity where medical therapy, which is predominantly anti-inflammatory, should be introduced early. In patients who have symptoms and also moderate to severe inflammation and endoscopy, do not waste their time on 5-ASA. We should always try to avoid 5-ASA in patients with small bowel Crohn's disease. 5-ASA's role in Crohn's colitis may be there for mild disease, but predominantly if you have somebody with with moderate to severe inflammation, jump to an advanced therapy upfront. Thankfully, with advocacy, we've been able to avoid, the step-up therapy that is, a barrier that is created by insurances, and many times we don't have to put patients through steroids and 5-ASAs before advanced therapy is introduced. And then, depending on the location, if you have perianal disease, we have the strongest evidence for anti-TNF agents. Anti-TNF agents are the oldest biologic agents available. However, The majority of them have a tendency to develop antibodies, and therefore I, in my practice, use it in combination with 6-MP azathioprine or methotrexate, especially for the first 1 to 2 years to avoid immunogenicity. However, that should not preclude you. If the insurance company doesn't approve it and you have other agents at your disposal and the patient has acceptance for that and no major contraindications, there is no reason that you cannot choose any other agents as such. However, certain phenotypes tend to respond to anti-TNFs better, such as extensive disease phenotype, penetrating disease phenotype, as well as anoperianal disease. What do we know about efficacy? And this is a very, very sobering fact. We do know that all these therapies are better than placebo. That's a given. However, despite having so many therapies available, we only have 3 head-to-head clinical trials that compare therapies, which is unfortunately driven by pharmaceutical companies who do not want to test one agent versus the other, because if their agent is not considered to be is inferior, it may drive them out of business. So the 3 trials, one of them is for ulcerative colitis, 2 of them are for Crohn's disease. The Varsity trial looked at bio-naive patients with a moderate to severe ulcerative colitis and compared vedolizumab to adalimumab standard dosing, which means no accelerated dosing. And in that study, vedolizumab was found to be superior. Now, it has a lot of caveats, but for just a simple statement, vedolizumab showed better outcomes as compared to adalimumab. CView looked at bio-naive patients with Crohn's disease, and they compared ustekinumab and adalimumab, again standard dosing, not allowed to have accelerated dosing, and both drugs were found to be similar. And lastly, earlier this year, we had data from the Sequence trial that looked at patients with Crohn's disease who were exposed to anti-TNF agents, and they compared risankizumab to ustekinumab. Now, risankizumab is an anti-P40 interleukin antibody, and risankizumab is a anti-P19 antibody, and ustekinumab is an anti-P40 interleukin antibody. So they're similar, but a little bit different. And in that study, risankizumab was superior to ustekinumab for endoscopic remission. So again, that's the data we have, and that's what I tell my patients if they ask me which therapy is better. Now, unfortunately, we don't have any head-to-head studies otherwise, and we have indirect data, which is too much to actually present in this study. But again, we have indirect observational data from network meta-analysis that has shown some superiority of one agent versus the other. But again, these are not randomized head-to-head studies, so therefore they cannot always be extrapolated to clinical practice. What I tell my patients is no medicine works for everyone. Everybody's different. Some medicines work faster than others. Anti-TNFs and JAK inhibitors, they tend to work faster than other mechanisms of action. What I do tell them is that the first therapy is usually the most effective, and that's what most trials have shown. So I do not keep an agent in my back pocket thinking that if one agent might not work, I will use it as a second-line agent. I tend to use the most effective agent that we decide upon, me and the patient, and use that as first-line therapy. And I also tell them that most clinical situations do not fulfill the criteria of published clinical trials. I also go over safety considerations. Patients who have prior allergy to one class of medicines or one particular medicine as such, we unfortunately cannot use it again unless we use certain medicines which only are pertinent if they have mild allergic reactions. Certain injectable medicines, they may have injection site reactions. We also look at concomitant medical conditions. If they're already immunosuppressed because of another concomitant medical condition, or they have a history of malignancy, then probably we choose medicines that are less likely to cause additional immunosuppression. We have cardiac risks to look for, and I'll discuss that in a slide that is coming up. And we also have to know that the majority of these clinical trials that looked at these medicines did not include the elderly. In fact, the elderly patient population over the age of 60 was responsible in only 1% of those clinical trials. And we at our center are doing some retrospective work that is looking at the utility of advanced therapies in the elderly patient population, and hopefully that data will be presented at DDW. And we also have special considerations for women of childbearing age, because we do know that JAK inhibitors and S1P receptor modulators are not recommended to be continued during pregnancy. The mode of administration is important. We do know that more and more medicines are being approved as injectable therapies. We have infliximab that is injectable now, vedolizumab that is injectable now, and after a few loading doses, they're followed by maintenance injections. However, there are patients who actually surprisingly they prefer infusions. They don't want to inject themselves. And infliximab, vedolizumab, you can send scripts for for their infusions at an outpatient infusion center or a home infusion or a hospital-based infusion center, depending on how convenient it is for patients and how it is approved by their insurance. Subcutaneous injections are easy to do. And you know, I have patients that are in different parts of the state. I mean, it's very easy to actually ship the medicine to their address and you know, subsequently, or hopefully, I mean, they are compliant with the medicine. And of course, there are now oral therapeutic options like S1P receptor modulators and JAK inhibitors that are taken, you know, orally, and that adds convenience. However, we do know that JAK inhibitors are not authorized to be used prior to exposure to anti-TNF therapy as per the FDA mandate. Talking about concomitant comorbidities that make an impact, we do know that anti-TNF agents, they're contraindicated in decompensated heart failure. You know, JAK inhibitors have shown some signal in the RA patient population in the older patients that they may increase the risk of blood clots. So again, something for us to think about. We do know that patients who have a history of heart block or macular edema, we tend to avoid S1P receptor modulators. So all those medicines, they have certain, you know, contraindications or relative contraindications that we have to look at when we are prescribing these medicines. It's important to know that and share that with patients. Again, there are medical conditions that actually help us in decision making about choosing one medicine over the other. We do know that for whenever there is involvement of joints, anti-TNF and JAK inhibitors, they have approved labels for rheumatoid arthritis, ankylosing spondylitis, atopic dermatitis, etc. So therefore, we can, in that situation, you can use, you know, a single medicine that can help, you know, several different organ systems. Psoriasis, you know, anti-IL-23 agents are actually very effective in that. So again, you can use that information to help your clinical decision making. Immunosuppressed patients, especially patients who are undergoing any kind of chemotherapy or have other immunosuppressing conditions, we'll try to avoid medicines that actually suppress their immune system even more. Most important of which is steroids. So I want you to also understand that steroids, especially in doses over 20 milligrams per day, they have a significant immunosuppression potential, and we should be avoiding their long-term use. And again, extraintestinal manifestations, because of their shared immunological pathway, may actually drive one medication over the other. So I want to spend a minute on insurance coverage, which in the United States is one of the biggest determinant, if not the biggest determinant, for choosing medicines. And this is the system we have, and we cannot completely, I mean, ignore it, and we have to go and play the system, you know, and be advocates for patients. And unfortunately, you know, now in my practice, as well as in other people who are practicing inflammatory bowel disease, our world does, you know, have a significant number of time that is spent on appeals, on peer-to-peer review, especially for off-label or accelerated dosing, and that creates treatment delays. And, you know, we do know that even if the medicines are approved, sometimes the co-pays can be, you know, very, very high and may preclude the use of these agents. Thankfully, from this, there's some support from pharmaceutical companies for patients who have commercial insurance that they may offer, you know, drug assistance programs at minimal cost for 2 to 3 years of therapy. But how I look at it is if I discuss this with patients, the choice of therapy, and we come to a common conclusion, I always finish the conversation that we'll be sending this to the insurance, and I hope that they'll be approving it. But if the insurance company doesn't authorize that one medicine, these are our second or third line options, and I would not waste time in terms of, you know, on an appeal or a peer-to-peer if we have those second or third line options approved through your insurance, because timing for me is everything. However, there are situations, of course, when they've burned through several rounds of other therapies that they only have one or two options. Then, of course, we try our best. We talk to insurance, you know, carriers. We do letters, appeals, and all that, whatever we can do to help our patients. But again, timing is everything. And if the patient is bio-naive, I mean, I believe that choosing one therapy that can be administered quickly may make a bigger impact than what exactly the therapy is. So my take-home, my recommendations and the take-home points from this is to have clear goals and expectations with your patients. Tell them that there is limited comparative efficacy data in terms of head-to-head clinical trials. The factors that I take into consideration include location of disease, the severity, the efficacy of medicines, their safety, their comorbidities, and insurance access. And I also tell them that the best therapy for patients with IBD is the one that works, the one that is a medicine that is accessible, one that both me and the patient itself feel comfortable with, and is hopefully able to bring a positive impact to their quality of life. Thank you very much for your attention.
Thank you, Asad. That was really a masterful presentation, explanation of a very complex topic. And you're such a trooper, because I know you're getting over a pretty bad cold you got through this entire presentation without coughing or or needing to take a sip of water. I'm really, really proud of you. And I also want to say that back when I was a fellow, the decision tree for biologic agents was a decision stick. It was just one thing, and it's absolutely remarkable what's happened over the last decade in terms of the number of medications that have been approved and the amount of complex decision making you need to navigate for each and every patient.
Yeah, I think it has really become very complex. And I think that has happened because our understanding of the disease has improved. We do know that there are, so many different factors, and, the epidemiology has also changed. I mean, we here in South Florida are seeing so many patients, over the age of 60 with new onset IBD. And, the clinic, I mean, that's one of the most, that's what keeps me interested in this field, is how quickly it's changing and how it's evolving, and how the care is not on a spinal reflex level. You have to individualize therapies. I mean, you create a lot of rapport with the patients, and it's very rewarding when you're able to create a positive impact.
Absolutely. Thank you. Okay, so well, a quick question before we move on to our cases and panel discussion. Dr. Bott has a question about if proctitis can advance to left-sided colitis due to screening for colon cancer after 7 years of proctitis patients, even though they may be in remission.
So the data suggests that patients who have proctitis, they do not have an increased risk of colon cancer down the line. So depending on, the risk of colon cancer increases in patients who have more than 1/3 of their colon involved for 8 or more years. But it's also important to know that a lot of these data on colon cancer, I mean, these are not new data. I mean, now that we have better understanding of the disease, once we have good control, not just symptomatic, but also on a biochemical and endoscopic level, I think that really drives down the risk of cancer in these patients.
Excellent. All right. Well, let's get started with our cases. We have two of our first-year fellows are rising stars, Christina Fernandez and Neelam Ketpal. We're going to start off with Christina. For continuity's sake, she's going to present something that's going to follow and I believe IBD, right, Christina? You're on? All right.
Yes, that's correct. Let me go ahead and share my slides here. Okay, can everyone see my screen?
Excellent. Yep, we can see.
Okay, great. So first of all, thank you all for having me here this evening, and this will be a tough act to follow. Dr. Rahman is my continuity clinic preceptor, and he's been an incredible mentor to me. So thank you, Dr. Rahman. So this evening, I'm going to try to keep it short and sweet. An interesting case of a patient that we had in clinic with leukopenia in moderate ulcerative colitis. Let me see. Okay, so just a brief history on this patient. She's 65. She has a history of class 3 obesity that had been complicated by severe OSA. She'd been on CPAP. She did have this initial diagnosis of UC back in 2011, GERD, hyperlipidemia, no prior surgeries. In terms of her family history, it is notable for UC in her father, as well as cholangiocarcinoma. Otherwise, no history of Crohn's, colorectal cancer, or celiac disease. For her social history, she lives at home with her husband. She works at a local university here in Florida. She's actually planning to retire in the near future. She's contemplating a move to Italy. Otherwise, no toxic habits. And for her medications, she's on rosuvastatin, she's taking fiber gummies, she's on a probiotic, she's taking vitamin D3 daily, vitamin B12, as well as calcium daily. Now, I purposely excluded her UC medications at this point, just for the purposes of the presentation. So just an overview of the timeline of her medical history here related to UC. So as I mentioned previously, she was diagnosed in 2011 with left-sided colitis after she initially presented with abdominal pain and rectal bleeding. At this point, no extraintestinal manifestations, and she was being managed actually for several years with a preso. So she did well up until 2019 when she started developing these frequent flares of UC with bloody stools and abdominal pain. She had intermittently been on prednisone throughout the years of 2019 through 2021. At that point, a colonoscopy had actually been done that showed she was now having mild UC pancreatitis. So it had progressed now from left-sided colitis now to pancreatitis, at which point now she was started on Lialda, 4.8 grams daily, and then a Euceris rectal foam in 2021. So she was followed up in clinic, and in December of 2022, she had been doing well, but then shortly thereafter began experiencing fecal urgency, some rectal bleeding. And at this point, a colonoscopy was pursued, which I will touch upon over the next few slides, now showing a Mayo 1 UC in her ascending colon, as well as Mayo 2 UC proctitis. We recommended just continue with the trial of Canasa, 1 gram rectal suppository daily, as well as starting this rectal hydrocortisone. Seeing that in January of 2023, she's been doing well on this rectal hydrocortisone, we actually recommended now decreasing this and actually with the goal of stopping the rectal hydrocortisone, but to now increase the Canasa suppositories to BID. So fast forward now to February, she's now on maximal oral and rectal therapy with mesalamine, but she's now still having recurrent symptoms after we had discontinued this rectal foam for her. So at this point, the conversation shifted a little bit. We needed to pursue more aggressive therapies for her. So going back to the initial colonoscopy that we had performed in December of 2022, I think this is a good stopping point to maybe just summarize the case here for all of our listeners. So she's a 65-year-old female. She was initially diagnosed now with left-sided UC, had been stable for many years on oral mesalamine therapy, and it's now progressed to a mild UC pancreatitis. She had been started on a max dose therapy of oral and rectal mesalamine. And now here, I think the description that we can all see is that she has a Mayo 2 UC proctitis. So we see loss of the vasculature, we see ulcerations, we also see just marked erythema here. So then now what are our options? So I think just in terms of thinking about this patient, as Dr. Rahman was alluding to earlier, it really is an individualized approach, which is what makes IBD so challenging, but so fascinating. There's so much now that we can work with. So, in light of her continued symptoms, we had an open conversation with her with what her goals were. And she really did not want to be taking anything like any infusions or any more aggressive therapies beyond an oral medication for her. So really, we had introduced ozanimod at that point, but other options that we had discussed that were not oral options for her were ustekinumab, vedolizumab, and even rectal tacrolimus. Ultimately, given her preference for an oral medication, we went ahead and we actually initiated the ozanimod for her. So we can see here now pre-ozanimod, December 22 on the left-hand side, we see the Mayo 2 UC proctitis, and then we see now follow-up colonoscopy October 2023 post-ozanimod. We see complete resolution of the Mayo 2 proctitis, which is pretty incredible.
So that's quite a few months between those colonoscopies. Christina, how are you guys? Assad, feel free to jump in here. I don't want to put Christina on the podium here, but how are you judging whether or not you need to continue therapy, change therapy, if you haven't looked at that area endoscopically for so long?
Yeah, so again, of course, once we start therapy, we follow the patient in the next 8 to 12 weeks to see how their clinical response is. Urgency is something that was the main driving symptom. So now we have that as part of our disease activity index. So her clinical symptoms improved. We also checked biochemical markers of inflammation. Calprotectin, which was several hundred elevated prior and had normalized. And normally in my practice, and most people who practice, this quite frequently, we wait about 6 to 12 months or so if the patient has had continued clinical improvement before we put a scope in, because that usually is the amount of time it takes to have definite endoscopic response. So again, this was done probably at the 10-month mark, but prior to that, we were reassured that the patient was clinically and biochemically doing well. However, if they don't respond, then of course it's reasonable to put a scope earlier or to switch to something else. Go ahead, Christina.
What about, just one more question, sorry.
Yeah.
What about imaging? What about the role of imaging?
So we can consider cross-sectional imaging. Normally, it does for CT scans. It requires radiation, contrast. MRI is very inconvenient, takes longer time. Ultrasound is something that has shown a lot of promise and that to show real-time inflammation, and it's very useful for patients who have ulcerative colitis and inflammation of the small bowel that is within the last 50 centimeters of the ileum. For the rectal inflammation, unfortunately, just because the rectum is located so far deep into the pelvis, ultrasound isn't the best test. But I believe now that we have the ability to do an intestinal ultrasound, and this patient has some left-sided disease. I mean, we could have used this if we had that available in our clinic at that time to also give us more reassurance. And that also adds confidence that we are heading in the right direction. And response to ultrasound is also very quick. Patients have decrease in bowel wall thickness and Doppler decrease in Doppler signal within 4 to 8 weeks. So it's a very quick indicator to actually demonstrate that we have good response.
So this is something you do in the office when the patient comes in for a follow-up. Basically, they're looking good, they're feeling good, but you say, okay, well, let's take a look. Right at the bedside.
Exactly. That's our, essentially a new stethoscope. It doesn't require bowel preparation. It's painless. It's done at the same time. It does require time though, and it has to, has to go through the insurance. But again, it is something that is a very valuable tool and actually avoids unnecessary CTs, MRIs, and in certain situations, endoscopy as well.
Wonderful. Dr. Gonzalez, you have your hand up?
Yeah, and Christina, you mentioned very specific options for the patients that you discussed with her. Was that because of her past medical history? Or I guess because of the cholangiocarcinoma, maybe you were thinking, like Dr. Rahman was saying, what comorbidities they have. And I think you mentioned that she had a previous history of cholangiocarcinoma, and some of these have been, associated with maybe decreased risk of malignancy.
I think there was family history of cholangiocarcinoma rather than a person.
Family history. Yeah. Okay, but she was an elderly lady, right? She was like 60.
She was over the age of 60. So again, and this was my definitely another learning point in this situation is this is not a situation where good is good enough. I mean, you have tried maximal therapy. The patient is already struggling, and being on intermittent courses of prednisone is never the right answer. So that's the reason we actually made sure that the patient knew that this is time to step up.
Great. Go ahead. Let's move on.
Okay, so as the title of the presentation alludes to, the plot thickens, unfortunately. So as we were monitoring her, now we're seeing, we obviously obtained baseline labs in February. This is at the time of initiation of the ozanimod. And then we're checking now 2 months after, and we notice this new leukopenia to 2.6. So then I think this is another good stopping point. So now what will we do next if we find this new leukopenia? And so in our case, we ended up monitoring the leukopenia. So we see now in June, she still had this persistent leukopenia. She had been feeling okay, but at this point, we didn't feel too comfortable just leaving it at that. We actually ended up broadening our workup, referring her to an infectious disease doctor, at which point she was tested for HIV. She had CD4 count that had been tested. She had been tested for toxoplasmosis. And so a broad net was really cast in terms of workup for her and this immunosuppression. Some things to note from her infectious disease doctor's evaluation, though, is that now her CD4 count was actually 59. And because it was so low, she had been started on Bactrim prophylaxis. In October of 2023, though, this dose was now reduced from daily dosing to now 3 times weekly, as her serologies for toxoplasmosis had resulted negative. And then as we persisted in monitoring her lab work, she still had, this leukopenia that was present, unfortunately. At which point, given, this ongoing persistent leukopenia and this ongoing concern for this, we revisited the conversation with her in terms of now what we would do next. And so the discussion at that point was really to decrease the dose of the ozanimod. And ultimately, given the persistence of the leukopenia, as you can see in the following set of labs, we actually switched over to Entyvio. She is doing well. We can see that the leukopenia has now improved following that switch. But something I just wanted to mention here is that that's definitely a major key takeaway for us. So really, there's a lack of oral therapies that fall between the 5 ASAs or steroid failure and the use of biologic therapy in the treatment options for UC. So Xanamod, it is a good oral option after 5 ASA steroid and thiopurine failure. However, we know that the mechanism of action, it does have an immunosuppressive effect. So it causes inflammatory relevant lymphocyte sequestration within lymphoid tissues. And so I just think it's important that us as physicians and patients should also be made aware that a reduction in the absolute lymphocyte count is an expected pharmacodynamic effect. However, with that being said, with the persistence of the leukopenia, as in this patient, really further infectious workup should be pursued and consideration should really be given at that point for alternative options of treatment.
Excellent. Very well done. Thank you. Okay, let's move on to our second case discussion and our last one. Dr. Ketball, take it away.
Is everyone able to see my slides?
Yes. Yep.
Okay. Hello, everyone. I am Neelam Khetpal. I'm one of the gastroenterology fellows at Cleveland Clinic, Florida. Thank you so much for having me, and it's a privilege to be presenting at this platform. I am presenting a case on EOE. So 54-year-old female with history of 54-year-old male with history of eosinophilic esophagitis and chronic allergic rhinosinusitis presented with worsening esophageal dysphagia. He has been having symptoms of esophageal dysphagia, which he described as having food getting stuck in his esophagus and slow to pass and requiring a lot of liquids to pass for some time. And he has had a couple of episodes where he had required induced vomiting to remove the food from his esophagus. Going back to his history, he has had dysphagia symptoms for more than 15 years, and he had an episode of food bolus infection 10 years ago. He was formally diagnosed with EOE in June of 2022 when he had this EGD, which showed benign intrinsic stricture in the middle third of esophagus. Scope could not be traversed, and he was not dilated at this point. At this point, he was started on omeprazole 20 milligram twice daily. There was no symptomatic improvement after 3 months. And after that, he was started on 6 food elimination diet, and he did not have any improvement at that point as well. And just going back one point, that pathology when he had the endoscopy showed 50 intraepithelial eosinophils in mid and distal esophagus. So at this point, he had endoscopy in January of 2023, which again showed benign non-traversing stricture at 34 centimeter from the incisors. Pathology did show some improvement in eosinophils down to 30 eosinophils per high power field in middle esophagus as compared to 50 at the time of his diagnosis. At this point, I would like to pause and ask Dr. Gonzalez what should be our next options at this point. I understand that during your presentation, you had mentioned if there is a component of fibrous stenoxing disease, dilation should be considered. But would you consider dilation at this point? Would you consider step-up therapy and wait to see how he responds, or would we do both at this point?
That's a great question. I would do both, but the question always arises: should we wait for the inflammation to go down, which he still has 30 eosinophils per high power field, or should we dilate right now? I think with someone where you're not getting a 9.5, 10 millimeter scope through the esophagus, dilation now is probably the best thing to do. I mean, this is an impending food impaction to happen. If this patient's not careful, he's going to come in at 3 in the morning and give you a hard time. But definitely he needs a step up in therapy. He has fibrostructuring disease, which I showed you in one of the slides. PPIs may only respond histologically 11% of the time. And he's still having symptoms. He still has more than 15 eosinophils per high power field, and he still has endoscopic severity. So definitely step up, but I would probably try to dilate him now.
Thank you so much. Going forward, at this point, he was started on budesonide slurry 2 milligram twice daily and maintained on omeprazole 20 milligram twice daily. And then he had a follow-up endoscopy in April of 2023, which showed these images We have grade 1 edema, grade 2 furrows, and grade 2 rings, grade 1 furrows, and grade 1 edema with EOE-ERF score of 4. And his lumen diameter was documented as 17 to 20 millimeter. Scope could be easily traversed. He was not dilated, and pathology at this point showed no evidence of increased intraepithelial eosinophils. Dysphagia symptoms had also improved at this point. So we recommended patient to continue with budesonide, but dose was decreased to 1 milligram twice daily because of the insurance coverage. And he was continued on omeprazole 20 milligram twice daily throughout rest of the 2023. He had a follow-up endoscopy in December of 2023, which is this one. And he did not have any stenosis. Caliber was okay. Pathology did not show any eosinophilia. His symptoms remain improved. And I think this is another stopping point here about maintenance therapy. So again, the question is, what should we do for maintenance therapy? And should we commit every patient with eosinophilic esophagitis to long-term maintenance therapy, or are there any specific criteria that who should be on it?
I think there's enough data definitely to support, number one, long-term maintenance therapy. Whether you control this patient with budesonide, should you go back to PPI or should you stay on budesonide? That's still a little unclear. Probably this patient that had a pretty critical stricture, I would continue on budesonide. But definitely, maintenance therapy decreases the eosinophil count and the inflammation long term. So you're going to prevent fibrostenosis, fibrostructuring disease, and improve their quality of life. So I think maintenance therapy definitely is key here. In my opinion, I would do probably budesonide long term in this patient.
Thank you. So we did recommend that he continue budesonide, but he discontinued it in December of 2023, shortly after that endoscopy, because one, he was having some nausea and there was insurance uncertainty. But he did continue omeprazole 20 milligram twice daily. He comes back to our clinic in February of this year with worsening daily dysphagia symptoms. He was having some heartburn, even though he was on omeprazole twice daily at that point. So we plan to increase his omeprazole 40 milligram twice daily. We suggested that he should go back either on budesonide or consider dupilumab, but he deferred at that point. He instead chose 2 food elimination diet, which is mainly wheat and dairy, as we all know. And he was recommended repeat endoscopy in 3 months. He underwent repeat endoscopy in November of this year, very recently, while he was on omeprazole 40 milligram twice daily. And this is what we saw on his endoscopy recently in November. So we can see definitely there is different from our most recent endoscopy in December. EOE-ERF score in that one was only 2 with grade 1 edema and some rings. But here definitely we have severe furrows, we have moderate rings. Caliber is very narrow. There was grade 1 edema. There was some exudates, stricture, and his lumen diameter was 13 millimeter, and at about 20 to 25 centimeters from the incisors, he had a tortuous esophagus, and there was resistance to the passage of the scope. So his score went from 2 in December to 7 in February this year. Now, this question is open to all the panelists. What do we think are the next best steps in the management of this patient?
I think again, I think dilation is important. We have a narrow caliber esophagus. I would even say the one that looked normal previously, that was in, I think, December 2023, that even looked a little bit more narrow caliber as well. And like I quoted before, the Mayo Clinic study, we're very bad at seeing whether these are narrow caliber, whether they need dilation. But he was asymptomatic, so I guess it's fair. But now he's having symptoms. You again see this narrow caliber esophagus. This isn't terrible, but enough to cause him symptoms, and a 13 millimeter diameter esophagus. So I would definitely dilate, and I would have a shared decision making discussion with the patient and really tell him, I know you don't want to do the steroids. When we last spoke a few months ago, you don't want to do the dupilumab, but really this is something that you need to really control the inflammation, and it's the best we have. Whether he wants to go back on budesonide, I know he's had issues with that before. I think that's a good option, has controlled his inflammation before, or whether he wants to do dupilumab. I mean, I know he has a chronic allergic rhinitis. I think both are good options, but something that you have to discuss with the patient as far as risks, benefits, and alternatives.
Yeah.
Thank you so much.
I agree. I mean, until we have a medication that can actually break down the fibrosis, I mean, you're going to have to dilate people like this to get them to feel better. Good.
Dr. Abraham, do you
Yes.
have any preference for dilation? Whether do you prefer through the scope dilator versus savory in these patients, or is there data to support one over the other?
Actually, great question. That's one of our Dr. Bhatt from one of our participants asked the same question just now. I prefer in these long strictures to use a savory dilator, and the reason is that you can the balloon dilators that we use, but these are almost all of them are the same. They're anywhere from 5 to 7 centimeters long. The savory dilators, it's essentially the entire length of the esophagus. So my preference is to use a savory. There is some thought about, there being two vectors of force involved when dilating with a savory. One is the expansile force, and also one the directional force. And so some argue that you can actually get a better dilation with it. I'm not so sure how much of an impact that makes, but certainly in patients with eosinophilic esophagitis, you can have a stricture in the top and then have another stricture at the bottom, and you can tackle both of them sometimes with the same dilator. They need to be, of course, similar diameters, but if it's short enough, certainly the balloon is okay.
So yeah, so I definitely agree with that. You can use both. There was a question from Dr. Bhatt, are both safe? I think the main reason that people don't dilate in EOE is the fear of perforation, because there were early reports of perforation with EOE, but a lot of these had to do, number one, with food impaction. So people were trying to dilate at the time of a food impaction. And, some of it may have been trying to push even the food bolus into the stomach. But if you look at the long-term data, and this has been looked at over the last 10, 20 years, it is just as safe as dilating a Schatzki ring if you're safe. You want to follow the rule of 3, go nice and slow. And the way I like to handle it is, because you mentioned 2 different diameter sizes, I like to do my first dilation actually with a balloon dilator. Why? Because, like I said, sometimes it's hard to perceive, is this, more 11 millimeters or 14 millimeters? And if I start with a smaller balloon, I can see it right then and there if there's a tear. And there is such a thing, this has been looked into, doing a pull technique. So you start at the G junction, you go to whatever you think the smallest stricture is, and if you're not sure, if you're not confident, you can start with the 10 to 12 balloon, and then, you go stepwise fashion. And yes, it's a little slower, but at least you feel comfortable dilating these patients and you can see the cut. And so you go to the size that you think, you pull it back, and then when you see that the esophagus is really stopping the balloon, there, okay, well, I went up to 11 and this is, where it's stopping me. So I'm going to put the balloon down, come here and go to 12. And there you can see, and really map out the esophagus. So I do like that. But if the patient comes in another time, well, I know that the last time I dilated to 12, the inflammation is controlled. So I'll just go with a, savory to 12, then I'll choose the next size, etc. And that way I can definitely get the whole esophagus you want to. But I do like to map it out with savory. And both are just as effective, both are just as safe. So whichever one you prefer, that's just the way I like to handle it.
Great. Well, don't
Right,
let us hang in suspense. What ended up happening with this patient?
Okay, so thank you all for your input. So we eventually went ahead and dilated this patient. As Dr. Gonzalez mentioned, we had actually started with 10, 11, 12, but we did not achieve adequate target. And by target, we mean that we want to either feel the resistance or look at the mucosa and see if we can see the tear. These are our targets to achieve the dilation. So we proceeded to 12, 13.5, 15 millimeter balloon dilator to a maximum size of 13.5. And we did get our target here, as we can see in these images that we saw the tear. and we were able to traverse the scope and see it beyond. So we discussed with patient, we recommended to continue Prilosec 40 milligram twice daily, and he was agreeable on starting dupilumab. We plan to follow him up in few months and see how he does. So I think the key takeaway points from this presentation are two. One, if it's a fibrostenosing disease and they have stricture, yes, it's important to give them anti-inflammatory medications, but it is also important to dilate them to also help improve their symptoms, quality of life, and continuing, because yes, you can control inflammation with the medications, but fibrostenosing disease is there. And second is a maintenance therapy to make sure that they do not relapse or recur once they stop the therapy.
Excellent. Thank you very much. Thank you, everybody. That is going to wrap up our program. It would just have a few more announcements, but before then, I want to thank our faculty, Dr. Gonzalez, Dr. Manziva, Dr. Rahman, and also Dr. Ketbal, Dr. Fernandez for your presentations. This was really wonderful, very well done. If there may be one more question from the chat, if you could answer that before they part, that'd be great. And I also want to announce that we are going to be having a conference in March in Florida at Margaritaville Hollywood Beach Resort. On March 17th to 18th, we're going to discuss the gut insights, basically topics just like what we discussed today, things that are hot news in endoscopy, that we're going to expand on, things like eosinophilic esophagitis, inflammatory bowel disease, hepatology and transplant, pancreas diseases, obesity. This is going to be really a 2-day course that's going to delve into the insights by Cleveland Clinic faculty and some renowned faculty from around the country for really topical content about gastroenterology. Next, coming up for the Cleveland Clinic, Live from Cleveland Clinic series is going to be on, here's the January 8th, multidisciplinary obstructive pelvic pouch dysfunction, and then multiple topics going on the rest of the year. There's the QR code that will give you access to all of these different lectures coming up. And I'm sure there's going to be more even filled in as the year goes on. Thank you again for coming and joining us tonight. I appreciate your input and look forward to seeing you again at a later conference. Thank you.